My name is Andy Bomback. I'm a nephrologist from Columbia University in New York City, and delighted to be down here speaking to you today about the use of mineralocorticoid receptor blockers in patients with chronic kidney disease. So I'm sure you're well aware of the use of spironolactone and eplerenone in patients with chronic heart failure. What I'm going to do today is sort of show you the growing use of these agents in patients with chronic kidney disease. So, it's fine. We will start with the question of why are nephrologists in general interested in aldosterone again? It's an old hormone, but we have a renewed interest in it. So I'll go into why we're interested in this hormone again. We'll then get into the question of, well, our patients are already taking ACE inhibitors and angiotensin receptor blockers. Isn't that enough? Why aren't those drugs enough for blocking aldosterone? And then finally, we'll spend some time going over the data on using aldosterone blocking agents in chronic kidney disease. What's the efficacy data? What's the safety data? And what future directions are we headed in? So we'll start with why are nephrologists, again, interested in aldosterone? Why are we seeing this renewed focus on aldosterone? And it's very important to know that aldosterone essentially has two faces. There's two sides to aldosterone as a hormone. There's the classical side that you learn about in medical school or in nurse practitioner school, is essentially what the hormone was originally known to do, which is stimulate receptors in epithelial targets to reabsorb sodium. Water follows, potassium goes out, so sodium reabsorption, potassium excretion. And if this hormone is too elevated, you can get hypertension. So you see these in things like aldosterone-producing adenomas, or in rare diseases like pseudo-hyperaldosteronism, where you're chronically stimulating the aldosterone receptor. Patients become markedly hypertensive. It's a form of secondary hypertension. And all that remains very interesting to us. But that's not what's gotten us more excited recently. What we're looking at now are what we call the non-classical effects of aldosterone. These are effects of aldosterone binding to mineralocorticoid receptors in off-target cells, targets in the kidney, the heart, the peripheral vasculature, and the central nervous system. And when aldosterone binds to these off-target cells, these non-epithelial effects include a marked inflammatory response, an oxidative stress response, and the end result, if it's not checked, is fibrosis, chronic damage to the organ, and we see it manifested as chronic kidney disease and congestive heart failure. So I want to go through a study that's about 20 years old now, but it's a seminal study in identifying these non-epithelial effects, these pro-fibrotic effects of aldosterone. It's an animal study, and there's 4 groups of animals, and I'm just going to go through each of them quickly to sort of lay the land as we start to look at what aldosterone can do. So the first group is just a sham group. Nothing's happening. It's a control group of animals. The next group is called the remnant kidney model. And this is a 5/6 nephrectomy model where you remove a large portion of the animal's kidneys. And that's a very good marker of chronic kidney disease. That's a model that we use for chronic kidney disease. It's essentially a marker of chronic damage to the kidney. Then you take that remnant kidney model and you give an ARB, an angiotensin II antagonist, losartan, irbesartan, but an ARB. Then you give that remnant kidney model an ARB, but you infuse back aldosterone. So you're blocking all the parts of the renin-angiotensin-aldosterone system that are proximal to angiotensin II, and you're isolating the effects of aldosterone. So let's look at the animals. Well, the control group, not much aldosterone. That's our control. The remnant kidney model, this 5/6 nephrectomy model that we say is a good model of chronic kidney disease, very high levels of aldosterone. And just keep that in mind. We'll show this type of data later. Chronic kidney disease, the worse it is, the more likely your patient is going to have some degree of hyperaldosteronism. If you give an ARB, you can reduce the aldosterone concentrations very nicely. But here they show that even with the ARB, if you infuse back aldosterone, you can get the aldosterone levels to a very high concentration. Now let's look at what happens to the animals after 4 weeks. Control group, nice blood pressure, normal size heart, very little kidney scarring. That's our control. The remnant kidney model, this 5/6 nephrectomy model of chronic kidney disease. Very high blood pressures, enlarged hearts from left ventricular hypertrophy, heavy proteinuria, and kidney scarring, glomerular filter scarring. That's what's happening in chronic kidney disease. If you give an ARB, you can abrogate those effects. The blood pressure comes down, the heart doesn't enlarge, there's barely any proteinuria, and the scarring is minimal. That's the good news. If you give the ARB, but you introduce back aldosterone, so now we're isolating the effect of that hormone, blood pressure goes up again, not all the way to the remnant kidney level. So a lot of the effects we'll see here are from blood pressure, but some of the effects we would say are blood pressure independent. Left ventricular hypertrophy again, heavy proteinuria, similar degrees of kidney scarring as we saw. So you can see that aldosterone is able to do the same degree of scarring that we saw in the 5-6 nephrectomy model, even though you're blocking the earlier parts of the renin-angiotensin-aldosterone system. So this hormone is particularly dangerous for the animal and for the patient. If you were to biopsy those animals, giving them aldosterone infusions, and importantly, they're also on a high-salt diet, you see cardiac fibrosis, and you see glomerulosclerosis, which is the kidney's version of kidney fibrosis. You're scarring down the heart, you're scarring down the kidney. How is it doing this? Well, there's a number of proposed mechanisms. They essentially start with the idea of an inflammatory response, in turn leading to deposition of collagen and overall fibrosis. So just thinking about it, the inflammation will in turn lead to scarring. And there's a lot of proposed mechanisms, a lot of potential culprits, inflammatory cytokines, vascular smooth muscle cell dysfunction, the metalloprotease activity leading to collagen deposition. None of these has been put forward as the number one answer. It's probably multifactorial, but on a very 5,000-foot view, it's inflammation leading to collagen deposition, leading to fibrosis, leading to end organ failure. Now, what's important about these studies is that not only do they show what aldosterone can do in the setting of a salt infusion, they also show that blocking the mineralocorticoid receptor pharmacologically with a drug like eplerenone or spironolactone can abrogate those effects. So we do have some help. We can potentially block this using mineralocorticoid receptor blockers. So here, looking at plasma osteopontin, which is a marker of collagen deposition, looking at albuminuria, which is a marker of kidney inflammation, looking at interstitial fibrosis, which for us on a kidney biopsy is a marker of irreversible kidney damage. All of that can be abrogated, can be diminished by giving those animals eplerenone. So we do have some potential help pharmacologically. Now, when I was a fellow, I was interested in aldosterone, and one of the things that my mentor and I discussed was, well, why do we even have this hormone to begin with? If it's such a noxious hormone, if it has so many bad effects, why do we even have it at all? And so we started to think about this from an evolutionary standpoint and started to think about, well, what would our ancestors have done with aldosterone? And one of the ways we tried to answer this question was looking at a Brazilian pit viper called Bothrops jararaca. And the reason why we looked at this pit viper was because this viper's venom is where captopril, the first ACE inhibitor, was developed. So then we said, well, why would a snake be walking around with an ACE inhibitor? Let's try to figure out what's the competitive advantage for a snake to be walking around with an ACE inhibitor. Diabetic snake. Yeah. So we then said, well, who's it trying to kill? And so an example of the type of prey that this snake might be trying to kill is the Yanomammal, which is a primitive tribe that was studied by anthropologists, and they had essentially not been westernized, and they were very close to what we think our ancestors were in terms of lifestyle. They were a low-salt culture, a hunter-gatherer culture. They relied on their renin-angiotensin-aldosterone system just to maintain normal blood pressures, actually low normal blood pressures. When they were studied by anthropologists in the 70s, their average blood pressures were 90s to 100s over 50s to 60s, which were amazing blood pressures. And yet, when they looked at their renin-angiotensin-aldosterone systems, their aldosterone levels and their renin levels were sky high. So these levels would actually prompt a call from my lab saying we have a critical value for aldosterone and we have a critical value for renin. These are more than 6 times the upper limit of what Columbia's lab would call normal. And yet, these individuals needed very high renins and very high aldosterones to maintain these very low normal blood pressures. And the reason why this is all working from a physiologic standpoint is because they're on such a low salt diet. When they measured how much salt these individuals were eating, they were only eating, on average, about 250 milligrams of sodium a day. Compare that to the average American diet, which is somewhere to 4,000 to 5,000 milligrams of sodium a day. So when you have these types of levels of hyperaldosteronism in the setting of very low salt, it's fine. We have a natural experiment of this in nephrology called Gittleman syndrome. So Gittleman syndrome is a salt-wasting nephropathy, where essentially, even though the patients can eat a lot of salt, they don't take in any of it. The kidney wastes it, so they're essentially in a low-salt state all the time. They also, because of all that salt wasting, tend to be very hypokalemic. And when I asked my mentor about Gittleman's, and he had studied under Gittleman, because I was at North Carolina and Gittleman was a professor there, he said they had seen up to 50 cases of Gittleman's, and they had never had any cardiovascular events in that group, despite those patients being profoundly hypokalemic. And you would expect, because the potassiums are so low, that they would have had these cardiovascular events. And yet the patients never developed any cardiovascular disease. And that, we think, is because even though they had such ramped up renin-angiotensin aldosterone systems, they had no salt cofactor. The problem is most of our patients are walking around with these conserved, from evolution, these evolutionary conserved hyperactive renin-angiotensin aldosterone systems, but they're doing so in the setting of a moderate to high salt diet. And that's not okay. And the activation of the mineralocorticoid receptor by aldosterone in the non-classical targets, these pro-inflammatory, pro-fibrotic effects, they must occur in the presence of high extracellular sodium. And it's when aldosterone is there in the presence of high extracellular sodium that we see this inflammation, we see this injury, we see the development of cardiac fibrosis, we see the development of glomerulosclerosis, and eventually see patients with chronic kidney disease and chronic heart failure. So what I'm really getting at is that it's aldosterone and salt. And salt is a very key cofactor in flipping aldosterone from being physiologic in a low salt setting, because there you do want to hold on to sodium, to being pathophysiologic in a high salt setting. And there you're actually seeing not only hypertension by its classical effects, but you're seeing fibrinoid necrosis, inflammation, collagen formation, and fibrosis via the non-classical effects. So it really does a shift in the setting of what environment it is. And again, just to sort of hammer home this idea of evolution gone bad, or putting our old genes in the wrong environment. In the setting of low salt, aldosterone activates the mineralocorticoid receptor appropriately. In the setting of high salt, and in particular in obese patients, you overactivate the mineralocorticoid receptor, and we see the development of chronic kidney disease as well as cardiovascular disease. Now I want to sort of show you what happens when we load up with salt, and this curve is going to come back later in the talk. If you take healthy individuals and you load them with salt, as they eat more and more salt, their aldosterone secretion goes down. That's a normal physiologic response. You're loading up with salt, you're essentially expanding volume, you're going to decrease the renin-angiotensin aldosterone system, you lose stimulus to aldosterone production, aldosterone levels go down. So that's a normal physiologic relationship. And yet, despite the increased salt intake suppressing the renin-angiotensin aldosterone system, I've just spent the first 10 minutes or so saying that when we increase our sodium intake, the renal injuries that are mediated by aldosterone are augmented. So that's a paradox. I just told you that as you eat more salt, you suppress aldosterone, but all the way leading up to that, I said that aldosterone has its worst effects when you're eating salt. So how do we reconcile that paradox? Because that's a true paradox. So the explanation that we've come up with is called relative hyperaldosteronism. And what we're saying here is that, yes, Here is the normal, healthy, physiologic state. The more salt you eat, the more you suppress aldosterone. But this is the pathophysiologic state. The more salt you eat, yes, you suppress aldosterone, but you just don't do it enough compared to the healthy individual. If you are in a state where you're not suppressing aldosterone to ideal levels, you have relative hyperaldosteronism. It may still be within normal range for your lab, but for the degree of salt that you're eating, and compared to people who are healthy, it is still too high. And it's this inappropriately high or relative hyperaldosteronism, particularly when you're eating salt, that's activating those mineralocorticoid receptors and off targets, leading to inflammation, leading to fibrosis, and leading to end organ damage. And the states where we see this all the time are chronic kidney disease, congestive heart failure, particularly in obese patients, and particularly in patients who have resistant hypertension. And this is relative hyperaldosteronism. Chronic kidney disease, which is what I'm interested in, is a state of chronic relative hyperaldosteronism. Again, think about the patient with chronic kidney disease. As the GFR falls, you expect them to become more and more volume expanded. And that volume expansion should suppress renin-angiotensin-aldosterone. But instead, as GFR falls, as you get to stage 3, GFR less than 60, to stage 4, GFR less than 30, to stage 5, GFR less than 15, plasma aldosterone is actually rising relative to the degree of volume expansion. You're seeing worse and worse and worse relative hyperaldosteronism as the chronic kidney disease gets worse. This is a project I did as a fellow going to dialysis clinics, measuring aldosterone levels in dialysis patients and comparing it to how much extracellular volume expansion they had. So we just measured aldosterone levels at different times during the week based on different intradialytic weight gains. And we showed, using a bioimpedance machine to measure extracellular volume, that as you expanded volume, you did in fact suppress aldosterone if you were end-stage renal disease. But when we compared it to healthy volunteers going from low-salt diets to high-salt diets, you can see that the dialysis patient never suppresses his or her aldosterone levels to the same degree as someone who's healthy. This is relative hyperaldosteronism of kidney failure. Those experiments were then extrapolated to earlier states of kidney disease, CKD3, CKD4, CKD5. And this is where we start to see relative hyperaldosteronism occur as soon as you get your GFR less than 60. And again, the worse the kidney failure is, the worse the degree of relative hyperaldosteronism is. So now the question to ask is, well, okay, you've shown us this problem, but what are you doing about it? And I think the logical question is, aren't you guys giving ACE inhibitors and ARBs to all these patients? You know, nephrologists have pushed these drugs so much, and we are getting as many patients as possible on ACE inhibitors or ARBs. These are standard of care therapies. Why aren't they helping those patients? Why aren't they keeping aldosterone levels down? Why aren't they tackling this relative hyperaldosteronism? And the answer to that is a little bit tricky. But yes, in theory, if you block ACE with an ACE inhibitor or you block angiotensin II with an ARB, you should affect aldosterone downstream. But theory doesn't always match practice. And what we see in patients who are put on ACE inhibitors or ARBs is that some patients do in fact suppress aldosterone. You see, once you get them on an ACE or an ARB, this expected decline in aldosterone levels. But some patients break through. That's the term we like to use. It's called aldosterone breakthrough. And the aldosterone levels are initially suppressed, but by 6 months, the aldosterone levels have actually gone up compared to where they were before they started therapy. And the aldosterone level remains elevated while they're on the ACE inhibitor or the ARB. Now, some people have called this aldosterone escape, but there's a different type of aldosterone escape that has nothing to do with this. So just for semantics, I like to call this breakthrough. It's the same idea, though, if you see the word aldosterone escape in some of the coming slides and some of the literature. So how often does that occur? Depends on how you define it, but if you use the most traditional measurement, which would be checking an aldosterone level before you start therapy and comparing it to aldosterone levels at 6 months and 12 months after you start therapy, it's about 1 out of every 3 patients, which is a very large number. So 1 out of every 3 patients that you put on an ACE inhibitor or an ARB if you were to measure their aldosterone levels 6 to 12 months later, the aldosterone levels would actually be higher. They've broken through the ACE inhibitor or the ARB. Now, I would love to say that a nephrologist is the one who really put this on the map, but it was actually a cardiologist who really pushed this. And this is Bertram Pitt, who is a very well-known cardiologist, particularly in the world of aldosterone. And in '95, over 20 years ago, in what was sort of considered a white paper, a methods paper for a study that was being done called the RALS study, which became a landmark congestive heart failure study that used spironolactone in CHF patients. The rationale for why they thought spironolactone was going to work was what he called escape of aldosterone, or what I would call breakthrough, in patients who are on ACE inhibitors. Saying, well, we have all these patients on ACE inhibitors, but they're still progressing. They're escaping the drug, and now we're going to block it with spironolactone. And that's exactly what the RALS trial showed, is that you take patients with CHF already on an ACE inhibitor, give them spironolactone, and the survival was significantly better. And then a few years later, they did the same study with eplerenone. Now it's ACEs or ARBs using eplerenone, and you saw the same reduction in cardiovascular morbidity and mortality by blocking aldosterone. So again, this idea that even though the patients were on ACEs and ARBs, it just wasn't enough for them, adding mineralocorticoid receptor blockade significantly improved heart outcomes. That's in the CHF population. Now, why is this breakthrough occurring? So as you try to figure out, well, why are patients breaking through ACEs and ARBs, it would be logical to say, well, let's look at what stimulates aldosterone. Maybe there's something going on with the drug that's stimulating aldosterone production. And the two main stimuli to aldosterone are volume via angiotensin II and potassium. When you look at the data in the breakthrough studies, neither potassium levels or angiotensin II levels have actually been correlated with breakthrough. So that really didn't bear out. When I was getting interested in this field, one of the theories that was put out there was maybe we're just not blocking the system early enough. Maybe we're getting an override, that the system is sort of revving up and getting around ACE inhibitors and ARBs, and there's a potential benefit to blocking the system earlier than at the level of ACE. And that's around the time the renin inhibitor was coming to market. So we actually did a study at Columbia looking at breakthrough with aliskiren, which was the renin inhibitor. You'll notice I'm using past tense because that drug essentially no longer is being used. Valsartan, which is an ARB, and then a combination of the renin inhibitor and ARB. Our hypothesis at the time was that the more proximally you inhibited the renin-angiotensin-aldosterone system, the better chances you would have to reduce this aldosterone breakthrough. We enrolled typical chronic kidney disease patients with proteinuria, with some reduction in GFR, with hypertension, and we did the typical measurements of sodium, aldosterone, potassium, etc. over a year. We did see breakthrough. So breakthrough occurred in about 25 to 30% of patients. Whether we were measuring it in the urine or in the serum, we saw that there were some patients whose aldosterone levels were rising on therapy versus some who were suppressing it as we would want to expect. Interestingly, though, the breakthrough rate was no different across the groups. So whether you're on an whether you're on a renin inhibitor or an ARB or a combination of a renin inhibitor or ARB, the breakthrough rates were essentially exactly the same. No statistical difference, anywhere between 25 and 30%. And around the same time, the AVOID study, which was a multi-center study looking at aliskiren use in diabetic nephropathy, published very similar results, that they were seeing similar rates of breakthrough with an ARB alone versus an ARB plus a renin inhibitor. So it looks like the renin inhibitor doesn't help prevent breakthrough. So then what do we say? If the renin blockade can't prevent aldosterone breakthrough, what's causing this? Well, the next thought was maybe there's something even more proximal to renin, something like prorenin, and maybe potentially we could block that. Or potentially aldosterone breakthrough is due to a stimulus to aldosterone production that's outside of the renin-angiotensin-aldosterone system. And when we looked at our data, we saw that the subjects who broke through were significantly heavier, had BMIs above 30, compared to subjects who did not break through, BMIs less than 30. Now that hasn't been shown in all the breakthrough studies, but there is good physiology behind this. Adipocytes, fat cells, actually secrete something called a mineralocorticoid releasing factor. that stimulates aldosterone production. If you take a zona glomerulosa cell from the adrenal gland and put it in a fat cell medium, that cell will become hypersecretory and actually start overproducing aldosterone. So it's possible that, at least in this study, all the breakthrough that we were seeing was an obesity-related form of hyperaldosteronism. Regardless of what causes the breakthrough, we know it's occurring. We know it's occurring in about a third of the patients on the ACEs or ARBs. And we know from studies that when it does occur, it has consequences. It's not just a lab phenomenon. It actually has clinical consequences. If you compare patients who don't break through, these are the ones who suppress aldosterone, to those who do break through. The non-breakthroughs, when you put them on an ACE or an ARB, they show over the long term a reduction in left ventricular mass index, this improvement in LVH in somebody with heart failure. But the patient who does break through, whose aldosterone levels rise with treatment, their LV mass index rises. So the cardiologist who wrote this paper said that aldosterone breakthrough may be the reason why we see refractory LVH in patients who are on ACE inhibitors or ARBs. In diabetic nephropathy, there are some patients we put on ACEs and ARBs who just don't drop their protein as much as we'd like to see. Again, here they're using escape instead of breakthrough, but if you break through versus if you don't break through, your proteinuria is about 4 times higher than what it was if you did break through. And that's purely, we think, mediated by the fact that the aldosterone levels went up during therapy rather than went down during therapy. So aldosterone breakthrough associated with refractory LVH, aldosterone breakthrough associated with refractory proteinuria. This is a study in IgA nephropathy which shows the same data in terms of proteinuria. The breakthroughs are showing higher levels of proteinuria compared to those who respond to the ACE inhibitor or the ARB. And then looking at GFR decline, which is really what we're most interested in, trying to protect renal function. In a diabetes study at the Steno Diabetes Center, very large study in Denmark, the aldosterone breakthrough patients had twice the rate of GFR decline to the patients who were able to suppress aldosterone. So a 5 ml per minute per year reduction in GFR is very fast decline of kidney function compared to what you would expect in a diabetic on an ACE inhibitor of about 2.5 mLs per minute per year. So this has real clinical consequences. And this is why I think we do have good rationale, just as the cardiologist did 20 years ago in designing the RAL study, to think about using mineralocorticoid receptor blockers in chronic kidney disease. So there are some trials that have looked at using mineralocorticoid receptor blockers in chronic kidney disease. Some have been bigger than others. Some have been well-designed, randomized trials. Some have been more uncontrolled trials. But the overwhelming sign that we see from the data, to sort of summarize before we get to the data, is that they tend to work and they tend to be safe if you do the right patient population. So these are the first 8 studies that looked at spironolactone or eplerenone at very low doses. Same types of doses they used in RALS and Ephesus. These are not diuretic doses. These are purely hormonal blocking doses. 25 of spironolactone, 50 to 100 of eplerenone. And what they showed was that if you put these drugs on top of pre-existing ACE inhibitor or ARB use, and you compared them to just being on an ACE or an ARB, the reductions in proteinuria, which for us is an important surrogate outcome, was about 40 to 50% in the parallel studies and about 30 to 40% in the crossover studies. So very nice reductions in proteinuria beyond what an ACE inhibitor or an ARB could do by itself. And in the non-randomized trials, that same signal emerged as well. So again, already on an ACE or an ARB, getting the maximum proteinuria reduction you can get from those agents, then you add spironolactone or eplerenone, you get an additional 30, 40, 50% reduction in proteinuria. This is a study I did in conjunction with the group from Poland where we said, well, how low can we go with the spironolactone? Just thinking about safety issues, the lower the dose, maybe the better the safety profile. So we used what we called an ultra-low dose of just 12.5 milligrams per day. And we sort of stacked the deck by saying we're going to take obese subjects with resistant hypertension, so really that classic relative hyperaldosterone phenotype, who already had evidence of target organ damage, either LVH or fundoscopic changes or proteinuria, already were on long-standing ACE inhibitor therapy, and we looked at blood pressure and proteinuria. Blood pressure went down. It was a short study, only for 4 weeks, Blood pressure went down with spironolactone. As soon as we took the drug off, the results were reversed. That was in the office. Same thing we saw with ambulatory blood pressure monitoring. Same thing we saw when we just looked at nighttime blood pressure. As you know, you want the nighttime blood pressure to drop. That 10% drop in nighttime blood pressure, that's called dipping hypertension, is a very good physiologic sign for your patient. If you don't dip, you're at increased risk for cardiovascular morbidity and mortality. So this was a very nice study in terms of the blood pressure effects, and we also saw similar effects with proteinuria. Adding spironolactone, proteinuria dropped. When we took it off, the proteinuria rose again. So very promising results, again, using low doses of spironolactone, just 12.5 milligrams a day. This is one of the better studies, comes from Bob Toto's group, where they took patients with diabetic nephropathy, so diabetes, hypertension, and macroalbuminuria, already on lisinopril 80 milligrams a day, which is a pretty good dose of lisinopril. Most of us will stop at about 40. The more, cavalier might go up to 60, but 80 of lisinopril, you would be hard-pressed to say they're not on a maximum dose of ACE inhibitor. So they're on very good dose of lisinopril. And then on top of that, you were either randomized to placebo, losartan, or spironolactone. And what they showed was that the spironolactone group here in black had by far the best reduction in proteinuria, better than losartan, and better than placebo. So here the MRB outperforms the ARB and of course outperforms placebo. And the drop in proteinuria with spironolactone is a little bit over 50%. Great result. And it wasn't a blood pressure result. So the ambulatory blood pressure and the office blood pressures, there was actually no difference because they're using very low doses of these drugs. It's not an epithelial effect. It's a non-epithelial antifibrotic effect. And it seems to work extremely well in this population. The question you should be asking at this point is, wow, this looks great, but can I safely use it? Because one of the things that I've been calling these mineralocorticoid receptor blockers, but the other term that we use is potassium-sparing diuretics. And so you might be saying, this all sounds great, but I don't want to get called by the lab a week after starting the drug that the patient's potassium is 7. So can you safely use this drug? And we have some lessons from the cardiologist. What we know is that as this data comes out and it looks very promising, there is an increased risk of hyperkalemia that you can see in patients. So this was after the RAL study was published, looking at Canadian hospitalizations for hyperkalemia. And as soon as that study comes out, you see there's a lot more hospitalizations for hyperkalemia. So it turns out the reason why this was happening was that the RAL study had been designed with very tight inclusion-exclusion criteria, specifically trying to exclude patients that they thought would get hyperkalemia, including very elderly patients and, particularly notable for me, patients with reduced GFR. And a lot of this hyperkalemia were patients with reduced GFR. That doesn't help my case. But there is some good data. And this is data from George Bacris. And what his data shows is that, perhaps not surprisingly, what your kidney function is does predict how you'll respond from a potassium standpoint to these drugs. If your GFR is above 45, the rise in potassium that you see with mineralocorticoid receptor blockers is about 0.3 milliequivalents per liter, which is what you would actually see in most people with preserved kidney function. So that's what you would expect to see, and that's what you should be monitoring in your repeat chemistries that you do after you prescribe the drug. But if your GFR is less than 45, the rise in potassium on average is about 0.7 milliequivalents per liter. So that's actually very good data to have in your armamentarium when you're prescribing the drug. If you have a patient with a GFR less than 45 whose potassium before you start the drug is above 5, you might be in trouble. Conversely, if you have a patient with a GFR less than 45 and the potassium starting out is less than 4.5, you're probably going to be okay. It doesn't mean you can't use these drugs in any of these settings. It just means this is what you need to expect. And what we do at Columbia for patients with GFRs less than 45 is we treat them a little bit more gingerly than we do with GFRs above 45. If your GFR is above 45 and we start you on spironolactone, we check a basic metabolic panel at about 2 weeks after you start the drug. If your GFR is less than 45, we check the metabolic panel twice in the first 4 weeks. We check it at 1 week, and we check it again between 3 and 4 weeks. And if you get through that period, I'll show you the data. That's when the real rises occur, and then you should be fine. So this is a study looking at the safety of spironolactone in patients with mild to moderate kidney disease. GFRs on average were above 45, so take it with a grain of salt. But what they show is that when you start it, the rise of potassium occurs in the first week. The rise in potassium goes up by that 0.3 expected rate. When you take the patients off the drug, put them on placebo, the potassium will go back down. If you keep the patient on the drug, the potassium does not keep rising. All the way out to 40 weeks, but that rise all occurs initially. So once you get through that initial period, your patient should be fine. This is data from patients who are on dialysis. So there's an obvious, interest in using these drugs in dialysis patients because the number one cause of death amongst dialysis patients is heart disease. So can we use these drugs in dialysis patients to reduce morbidity and mortality? And can we do it safely? So this is a study looking at spironolactone or placebo. And as you can see, there's not that big of a difference in what happens to potassium when these patients are given spironolactone in the dark circles versus placebo in the clear circles. And none of them are getting above 5.5. If you look at the sort of averages, yes, spironolactone raises the potassium in the dialysis patient compared to placebo. But look at where they are. They're still less than 5 on average. So as long as you're starting with appropriate patients, you can use the drug safely, even in the dialysis population. And this is a larger study looking at eplerenone. But again, eplerenone versus placebo, the potassium changes are not that different, and they're all in a safe range, less than 5.5 milliequivalents per liter. So we can use these drugs with appropriate monitoring in patients with all degrees of kidney disease. You just have to be vigilant about monitoring the patients. This is the largest study. It's from the cardiology literature. And this was a study that looked at using spironolactone versus placebo in dialysis patients, looking at cardiovascular morbidity and mortality. This is the closest we've come so far to a nephrology version of the RAL study. I'm not going to show you the efficacy data, but just to suffice, it was a significant reduction in overall cardiovascular morbidity and mortality. It was a composite endpoint. But I just want to show you the adverse events. So the big adverse events, 16 of the 23 adverse events, were actually gynecomastia or breast pain. Only 3 patients had hyperkalemia adverse events. That's 3 out of 157. So the hyperkalemia risk, because you're in a trial where they're monitoring you closely, was very minimal. Now, what about that breast pain? What about that gynecomastia? Well, that's with spironolactone. So spironolactone is also called a first-generation mineralocorticoid receptor blocker. The second-generation mineralocorticoid receptor blocker is eplerenone. The other term for it is a selective aldosterone receptor antagonist. So spironolactone actually has some effects on estrogen receptors. And so that's why you see the gynecomastia in men, the breast pain and menstrual irregularities in women. Eplerenone doesn't have that because it's more selective for the aldosterone receptor. The third generation mineralocorticoid receptor antagonists are in study right now. They're in trials. They're not yet in clinical practice, but we expect that these are going to make their way out to clinical practice in the coming years. These are called non-steroidal mineralocorticoid receptor antagonists, and they're exquisitely sensitive and specific to mineralocorticoid receptors. And what's exciting about them is that compared to the earlier generation mineralocorticoid receptor blockers, they appear to have a significantly lower risk of hyperkalemia because of how selective they are for mineralocorticoid receptors. So this is a drug that was called BAY 948862 when it was studied in the earlier parts of this decade. Now it has a name. It's called finerenone. There was a study in JAMA last year in which finerenone was used in diabetics, looking at hypertension results. There's ongoing studies now using finerenone. We're one of the sites at Columbia as an antiproteinuric drug. I expect it's going to work just as well as the data I showed you in spironolactone and eplerenone. What I really want to see is the hyperkalemia data. Will it actually have less rates of hyperkalemia and less average rises in potassium than the older generations? If so, if those drugs make it out to market, I think those will become more and more commonly used compared to the older drugs like spironolactone and eplerenone. So to sort of sum it all up, and we'll have some time, I think, for questions, I want to sort of propose to you a potential new treatment paradigm for using aldosterone blockade in patients with kidney disease. You don't necessarily need to use this for everyone. You really want to make sure that if you're putting your patients on these drugs that do have side effects, including hyperkalemia as a risk, and there's side effects for you in that you have to be very careful monitoring their drugs and their potassium levels, you want to make sure you're giving it to the patient who actually will benefit from it. So one potential way to do this is to say, I'm only going to give the drug to the patient who actually needs it. And so this is a study of diabetic nephropathy from Japan that sort of sets out what this paradigm could look like. You take patients with diabetic nephropathy and hypertension who have blood pressures above goal, who have macroalbuminuria, and you put all of them on an ACE inhibitor for 6 months. And ACE inhibitors work. If you look at the averages, the blood pressures go down from 150 over 90 to 135 over 80. That's a nice drop in blood pressure. If you look at proteinuria, it drops almost in half from about 400 to about 200. So, I mean, that's why we use ACE inhibitors. On a population level, they work great. But if you tease out the data and you look at who escaped or who broke through versus who didn't escape or who didn't break through, there's a difference. So one group actually was able to suppress their aldosterone and the other group did not. And again, it came out to 18 out of 45, or about a third, and 27 out of 45, or about 2/3, in terms of who broke through, who didn't. Blood pressure was not a clue. You couldn't look at their blood pressures and say one did better than the other because they actually both dropped their blood pressures to the same degree. But remember, we're worried about the non-epithelial effects of aldosterone, not the epithelial effects. So we're not really concerned too much about the blood pressure effects. We're worried about the fibrotic effects. And when you look at the albuminuria, the group that broke through, their proteinuria essentially didn't drop at all. Starting at 390, they go to 370. That's nothing. It's the group that suppressed aldosterone that had the greatest drop, 390 to 120. So for these patients, you're done. You don't need to add more therapy. Keep them on the ACE inhibitor. They've done very well with the drug. But these patients appear to need some more therapy. And these are the patients that I think will particularly benefit from adding aldosterone blockade. And so that's what they did in the study. They only gave spironolactone to those patients. And then their proteinuria dropped. They dropped on average, and they dropped almost universally on an individual level. So this could be your paradigm. Put everybody on an ACE or an ARB, look at their aldosterone levels, look at their proteinuria levels, look at their overall ability to suppress or break through at 6 months, and only give aldosterone blockade to the breakthroughs. So to conclude, we are increasingly recognizing the pro-fibrotic effects of aldosterone. We'll always know in the back of our heads the classical epithelial effects of aldosterone, but what we're really interested in now is, can we block these deleterious non-classical effects of aldosterone? And the populations where we think this is going to be particularly important are in chronic kidney disease patients. We've already seen it very nicely done in CHF patients. And within those groups, the two patient populations that are particularly primed for benefit are the obese patients and the resistant hypertensive patients. When you put a patient on an ACE inhibitor or an ARB, just be wary that about a third of those patients will break through the drug. Their aldosterone levels will not suppress with the drug. They will actually rise. And when they do rise, from a kidney standpoint, they're at risk for refractory proteinuria, a more rapidly declining GFR and worsening CKD, and from a cardiology standpoint, refractory left ventricular hypertrophy. The early data on MRB use in chronic kidney disease, when you add it on top of an ACE inhibitor or an ARB, has been very promising. It shows that these drugs can reduce proteinuria. They do so with minimal risk for hyperkalemia. And we're starting to see some hard outcomes in the dialysis population that they've reduced cardiovascular morbidity and mortality. What I'm still waiting to see and what I hope to see is hard outcome data in the pre-dialysis population. And what I'm really eager to see is hard outcome data using the newest third-line agents to say these newest agents have the best side effect profile and are able to reduce the hardest outcomes. And in that case, we might really get a big impact on the #1 cause of death in CKD, which is cardiovascular disease. So I'll stop there, and if there's any questions, I'm happy to answer.